Last week, President Trump announced his American Patients First, a 50-point plan on reducing drug costs in the United States. I've read the plan. It's very well produced, glossy with pictures and graphs and everything. What it says, in essence, is we're going to do things like increase transparency, increase competition, lower drug prices. Okay, that's the what. What it's short on, like most things that come out of DC, is the how. On reading the plan, I was struck that this is a little bit like a football coach talking to his team before the game and saying the key to winning is we're going to score more points than the opponent. Okay, that's not real helpful, and it's incredibly obvious. So what the problem is here is we're talking about the what and not the how. Now, an interesting thing to understand on this is this plan was clearly input by and probably developed by the new Secretary of Health and Human Services, Alex Azar. Alex ran a drug company, one of the big ones. So, as some people like to put it, he knows where the bodies are buried. And if he's behind this, he probably has some pretty good ideas on how to reduce drug costs. So the big question is, okay, how will this happen? What's likely to come from this? What actions are likely to be taken? Well, we don't know right now, but we do infer, and we can infer, from some of the things that are talked about and some of the things that are in the plan, the areas that are likely to be approached. First of all, I wouldn't want to be working for a PBM right now. The PBMs, or the pharmacy benefit managers, are universally hated by drug manufacturers and not particularly loved by the physicians who prescribe drugs. Alex is likely to take aim at those folks. My personal opinion, fire away, Alex. They deserve it. I don't know what value they bring to the system, and if we reduce their part of it, hallelujah. Personal opinion. The other thing that's likely to happen is a significant approach on going after the high-cost drugs. We're not talking about trying to reduce the cost of penicillin by a couple of cents. We're talking about going after those drugs, things like rheumatologic infusion drugs, high-end neurologic infusion drugs, oncology, chemotherapy drugs, very high-cost drugs, and trying to go after those prices or those costs. This becomes a little sticky. First of all, how do you do it? And second of all, what is the impact of it and what are the side effects? As every physician knows, whenever you prescribe a course of treatment, you always have to consider the side effects. Some things that have been discussed and may occur are potentially changing the way that Medicare pays for those drugs. Right now, Medicare pays on an ASP plus basis, which is basically saying we'll take physicians' cost of the drug and we'll add 6% to it. Commercial carriers follow that methodology. Now, that's not necessarily bad, although the argument is it's inflationary, because 6% of margin on a drug that costs $1,000 doesn't give the doctor nearly as much money as 6% margin on a drug that costs $100,000. So there may be a change in the way that occurs. Some people have discussed an idea of taking the drugs and putting them into categories, where very low-cost drugs produce a higher percentage margin and very high-cost drugs produce a lower percentage margin, as a way to incentivize physicians to try to prescribe lower cost drugs. Another discussion, and even a discussion in the plan, was changing some of these drugs from Part B benefit, which falls under the physician compensation benefit, to Part D, which is where the prescription or the oral medications fall. Now, this could have incredible impacts. Questions become, could oncologists who don't have a pharmacy license actually bill under Part D for in-office infusions, or would they have to do it somewhere else? Again, something that's being discussed. There's an awful lot of discussion in the plan about negotiating at the government level. Well, if anybody's ever tried to negotiate against the government, they really don't negotiate. What they do is tell you what they're going to pay. And as the largest purchaser of healthcare, that could have a dramatic impact. One thing to keep in mind in all of this is that one man's expense is another man's revenue. This is a closed system. Every dollar in expense reduction that comes from this is taking revenue out of somebody's pocket. Now, that may or may not be bad. My, again, personal opinion, if that takes it out of the pockets of the PBMs, good on you. However, if we do something that significantly reduces the revenue of, let's say, oncologists or rheumatologists or neurologists, we've got to figure out what that impact would be. For most of my clients who are in the oncology field, 80% of their revenue comes from a drug. A lot of rheumatologists, 60% of their revenue comes from a drug. So we just have to be mindful of what the impacts of these are going to be. So my message to you and to my clients is this. Keep an eye on this. Alex Azar is a smart guy. He knows the industry. Secondly, Watch what's going on. Talk to your legislatures. Because the reality of this is a significant amount of lobbying money is going to happen in D.C., and usually the drug companies and the PBMs can outspend physicians. So keep an eye on this and talk to your legislatures. Prepare for the future. If you're one of those groups that relies on pharmaceutical revenue to pay your bills, you might want to think about diversification. I'll leave you with this. Remember that sometimes the side effects are worse than the overall problem. You can cure cancer or you can cure the common cold with chemotherapy. The problem is the side effects are horrible and much worse than the common cold. So let's make sure we do this right, we do it intelligently, and we don't make the problem worse by trying to solve this. Thank you and good day.